Right, good afternoon, everybody. Welcome to this meeting of the joint Cambridgeshire and Peterborough Health and Wellbeing Board and Integrated Care Partnership. Just a couple of preliminary points. Filming and photography are allowed at the meeting. So pictures and tweeting is fine, but can everyone please make sure that their mobile phones are on silent or vibrate whilst the meeting's taking place. The meeting is being live streamed and a recording will be available to view on the County Council's website. We have no fire alarm test planned, so if the fire alarm sounds, please leave by the nearest marked fire exit and assemble in the car park. The closest fire escape is through the middle doors on my left, past the water closet and kitchen. People in the room, many here will be aware that this meeting follows on from us having had a informal development session for members of the joint forum this morning, which was really helpful and productive. Clearly, we are both individually and collectively going to need to sort of pick up on the points we spoke about this morning about how we work and how we take some of our work forward and the style of our engagement and meetings, and we'll be doing that pretty quickly after today. It may flavour, I guess, some of how we go about the business this afternoon, but I think we probably recognise that we have some business that we just need to engage with this afternoon in the normal format. If I can begin by asking for apologies. Uem, you have to let us know.
Thank you, Chair. So we have received apologies from Councillor Lynn Ares, Julie Spence, Stuart Francis, Darrell Preston, Jed Coran, John Walk, Charlotte Black will be joining us via the Zoom link. Then Nicola Colley, Claire Higgins. We have also had apologies from both our Peterborough City Council elected representatives, Liz Wirtz and John Howard. Therefore, I am pleased to welcome our new substitute member from Peterborough Council, Jackie Allen. You're welcome. Thank you.
Yes, thank you for joining us, and recognise sort of last-minute circumstances, which meant that John Howard's not able to join us. Anyone else need to talk about apologies, or anyone here who we haven't captured around the table? Okay, thank you. Declarations of interest. I think people have completed their declarations in most cases. Any particular declarations that people want to draw attention to in respect of today's business? Okay, there are none. So can we move to the minutes of our meeting on the 15th of July? Are there any points about accuracy of the minutes on the 15th of July that anyone wants to raise? In which case, are we happy to approve those minutes? Thank you very much. First substantive item then, I think, is about sort of our partnership and integration work and a person's story. I'm going to hand over to Jane Wilson to talk about that work in just a moment. Just before I do, I'm going to ask Kit Connick just to say a very brief introductory word before we pass over to Jane. Kit.
Thank you, Chair. So we wanted to bring this example to the Partnership and Health and Wellbeing Board because it was an initiative that's been supported by the integrated care system, where we enabled all district councils to have some monies to support local and community engagement and prevention work. And this initiative was a collaboration between 3 district councils and the South Place, and is an example of some of that work that was funded centrally and is ongoing. So this is why we wanted to bring it to this meeting for that purpose.
Thank you, Kit. Jane, over to you.
Thank you. I put in some slides. I don't know if they're going to be available. The slideshow.
So, looking at colleagues behind you,
It's fine if not.
do you have Jane's slides?
Well, I'll just start, and then
Okay.
hopefully if we can get them, that would be great. But
Thanks,
if not,
Deborah.
that's fine also. So first of all, thank you very much for inviting me here. I'm really hoping I can give you a sense of the project and the goals that we are aiming to achieve. And they're both short term within the lifespan of the project itself and longer term, and about how we function as a system. So it was a really good opportunity when that funding came through for the districts to bid around community engagement and prevention funding. And because of the work that had already been happening around South Place, City, South and East Cambs officers had been starting to work together and to think collaboratively around health well-being. So it made sense to really look at what we might be able to do as a collaborative project rather than 3 individual projects. And we spent some time identifying an issue which was relevant to all of us. Now, even in March, it was quite clear that a cost of living situation was very likely to emerge. And with that, increased pressures on the health system as people cut back on either heating or food or both. We at the City Council had already started to see increased cases of damp and mould in our own housing stock as people were turning off the heating. And we know the clear link between that, for example, and challenges with controlling or managing asthma. So we could see there was a real relationship between how we were going to help people with this crisis and how they were going to be interacting with the health service. So collectively, we agreed that we would work to 2 goals. The first one was a reduction in health harms as a result of the cost of living situation. So that's a really clear, sort of simple health-related target. But the other one was starting to really support the whole system approach that we've been working on in principle in the work developing South Place. And for me, this was not just about the work at the ICS, but also our own internal transformation program at the city, and really trying to think differently about how we would work. So we agreed 3 elements to the project. The first being a universal, the thing that we would all commit to, which was a shared commitment to awareness raising, visibility and staff training, all of which have been taking place, although I do have to say that the changing environment has really shifted what was needed in terms of awareness raising, because I think this is probably the top of everyone's list by now. But we are collectively involved in staff training, making sure that our staff who are going into people's houses know what to look for, it's not making every contact count, but it's almost a version of that, ensuring that people know what they're looking for and understand where they can start to direct people. We also acknowledged that we needed to be able to work locally, and I'm going to come on to that a bit more in the moment, because this is about the difference between having a general, we know that this is something that needs to happen, we know it's a shared issue, and what that actually looks like on the ground in particular localities. And finally, we agreed that we would share learning, we would embed collaboration, and we would make sure that we were communicating with each other as we went through. So in terms of that local co-produced element, what does that mean? The programs that are developed, on the one hand, are very similar. They've got key elements in common. There's a focus, as you would probably imagine, on warm spaces. There's a focus on communication. There's a focus on getting our staff in the right place to do this work. However, the 3 districts are very distinct. South Cambs and East Cambs, Cambridgeshire, are largely rural. They have a dispersed population. And the city is much more compact and has more significant, obvious areas of deprivation, as has been recently very well demonstrated by the data coming out of the population health management work in South Place. South Cambridgeshire and City both have direct housing stock, East Cambridgeshire doesn't, and we have a significant proportion of private rented housing in the city. So there are very different issues that we needed to tackle. Excuse me. So South Cambridgeshire and East Cambridge have actually collaborated at a very operational level and have procured Cambridge Acre to work with their communities to develop voluntary or volunteer-run warm hubs right across those two districts. And they will be very distinct, I'd imagine, in every place that they go. And Cambridge Acre are very good at that work, and they are delivering that on behalf of the two councils. In the city, we're in a different place. We've got a very active communities team of our own. We also have been running a community, a vaccine community champions project since January. Are you nearly caught up? I'm not sure. I'm going to try. Local and co-produced. So if you can go back one. I think if that's possible. Okay. So yes, I listed on the slide the kind of factors, geography, demographics, existing activity. So looking at the differences and trying to take a strength-based approach to going, well, what's already there on the ground and what can we build on? And that's the approach that we have used. So in the city, for example, there's a program of micro grants, which is building on the experience that we had through the Vaccine Community Champions. And we're working directly through our community services team to build the network of warm spaces across the city. So it just depends, you know, it's taking that broad principle as a key piece of work we need to do, and then thinking about how that works on an operational level in the different localities. I think that's it from that side. If we can move to the next one. The last thing I really wanted to talk about is the learning to date, and what have we found out so far? And top of the list is communication. If we're not talking to each other, we don't know what other people are doing. We can't learn, and it's a huge barrier. But it takes time. It's absolutely critical that we do this, but getting the commitment up front. So that time-intensive period when you're trying to find out who you should be talking to, trying to build a common language and understanding of what the issues are, and from that starting to get to a point where you can really develop the way that we're working together. It is a challenge. Teams are very stretched, and there can be a tendency under those circumstances to revert back to a more individual organisational solo type working. But what we've seen, and in, I think in real time, is that by putting some capacity up front at risk almost, when we weren't sure what was going to happen, we're starting to see real significant benefit in collaboration now. And at this point, I can speak very specifically for the city. We had an event which was hosted by the CCVS, which had over 60 different individuals and organisations represented, all coming together to look at this question and feed into our grants team how a micro grant scheme would work and how they wanted to see that happen. So it's galvanising a lot more activity through a much wider network than we would have ever been able to do on our own. So that's it, and I'm happy to take questions.
Jane, thank you very much. And I'm sorry we couldn't get the slides immediately, but I'm sure we've got the essence of that. Can I sort of ask whether people have got questions, comments for Jane? Mike.
Yeah, thank you. Mike Moore, Chair of Cambridge University Hospitals. Housing, how connected is the initiative to sort of housing associations and the private rented sector in terms of this? I imagine that is amongst the particular complexities of this.
Yes, something in the region of 40% of all of our houses in the city are in the private rented sector. So our environmental health team, who are our primary contact with that centre, are fully embedded in this project. We ran a landlords forum at the end of September, and the focus of that forum was this project, Heating and Health, and what role they can play. We've, in our most recent resident publication, which is called Cambridge Matters, which goes to every household, doesn't matter on the tenure, had a 4-page pull out on the key kind of opportunities people have, but also focusing on saying if you are a private sector rented tenant and you're not happy with what your landlord is doing, this is who you speak to at the council. So we're connecting up across all the teams internally that have a role and making sure that they're all aware and feeding into the information that we're taking out.
Thank you.
And the housing associations as opposed to PRS?
That the information is also going to housing associations, but the primary route to the resident is through the publication that we've just put through every single household, because that way we know we can get to them. We're also running 8 pop-up events across the city. They're taking place in a range of settings. The Central Mosque is hosting one, churches are hosting them, community group organisations are hosting them. So we're trying to get information, and the best thing about those is what we've got is potentially 15 to 20 different organisations putting their staff who can advise into the same place at the same time for the residents, so that instead of having to go round the loop, they get it all in one place.
I've got Paul and then Julie. Paul.
Thank you, Chairman. Jane, thanks for that. I think it's a really fantastic example. So, I mean, it kind of connects obviously with heating health, community engagement, prevention, as you've said. I think what's really interesting, I'm speaking with colleagues in the North Place, there's another very similar example in Hunts called the Warm Spaces Initiative, and that's led into a recent conversation about how we maybe sort of extend a kind of delivery model around a kind of early hub example. I suppose my question or observation, Chairman, is how we take forward, you know, positive interventions like this and coordinate them across the kind of whole system and the whole geographic place, so we don't lose sense of this good work that's been undertaken, these good examples that are coming forward.
Yeah, and perhaps come back on that specific point, Paul, in a second. Let me take Julie, and then we'll bring some of them back together.
Thank you, Chair. Hi, Jane. Nice to see you. A nice report. You mention in your report revolving around capacity issues. Can you tell us whether those capacity issues are specifically in one area, or do they cover all partners? Because I know that workforce issues, whether they be paid staff or whether they be volunteers, we're all experiencing that. And if that's the case, have you got any actions about how you might be able to relieve it?
It's not a simple one, Julie. I think the first thing is acknowledging that it's there, and then there are difficult questions sometimes about what do we not do, and what are we prioritising. I think one of the things we recognise at the council is that can sometimes be an unrealistic expectation of what the voluntary and community sector can take. So it's part of this process has been working with them up front to find out what's possible, and then not asking for things that can't be done. And I think in the city you can see that through the way we've been working with the CCVS. In South and East Cambridgeshire you can see that through the procurement of Cambridgeshire Acre to come in and do a lot of the heavy lifting with communities. So it's not an easy issue, and I'm very aware, for example, that we need to look at how we're working with our primary care networks and integrated neighbourhoods because of the time constraints that they have. But I think it's like we have to get going. We have to see how this works, and then we will learn and we will get better at it.
Jane, do you have any, I'll come back to Paul's point. Have you got any observations about how you're sharing some of that and therefore helping with coordination, but also future sustainability, I guess, those sort of questions? But it's a question for all of us, not just for you, but I'm just interested in your thought.
Again, I'll go back to we have to start somewhere, and choosing to work with the 3 authorities that are, coming into South Place, I think was a good way to begin that, because we're trying out how do we communicate. We're having meetings that have got City, South, East Cams officers, that have got ICS officers, that have got the voluntary and community sector represented, and having working groups that bring all of those people together. We're just, and it's working, but we had to figure out how to do it. I think then coming here and talking about what we're doing is important. But I think I would look to the higher level ICP to take that across the whole area.
Do you want to pick up on that?
Please, yes, thank you. So we've held one learning event so far in the summer, where we shared the initiatives and shared all of those proposals across all the district councils, so we can think about some of the themes, opportunities for learning, and any challenges, so we can share that. The next event is in November, and again, what we are working on with the community engagement colleagues is making sure we can have a map of all those heat hubs across the whole of the county, available on the integrated care system website, so it's more accessible. So these are initiatives that we want to roll out more widely and bring that learning across the whole system.
So, Paul, I guess we can pick that conversation up in the context of that facility and capacity. Any other questions for Jane? Just one from me, really, Jane. I mean, if you had an ask of us, either individually or collectively, about where you are now, what would it be?
Recognition of the role that districts can play, and the fact that we are so close to local residents, and then thinking about this in a slightly longer term way. It was great, and it was fantastic to get that funding, and it was brilliant to be able to put this initiative together. But I think it's now starting to think about, well, what does that mean in the longer term?
Jane, thank you very much. Thank you for the work, most important, and to you and all your colleagues who are involved in it across those areas, and for sharing some of that with us today. Really important in the context of the situation we currently face, and we'll look forward to making those wider connections. But thank you very much for sharing that with us. So I think we now move on to the Better Care Fund submission, and Caroline Townsend, I think, is joining us on screen. I hope you can hear us, Caroline, in which case,
yes.
Great, that's really good. And I'm sure you'll explain this, but obviously the submission itself is something which, for statutory reasons, has had to be made already, but it's important that it comes before the Health and Wellbeing Board more widely. But Caroline, over to you.
Thank you, Chair. Just to also say that my colleague Sandra Pedley is joined us virtually as well. So Sandra is actually commissioning manager in for the she's fine to answer any questions along with me. So we are bringing this report, as the Chair mentioned, for your review and also for retrospective approval. We were required to submit local Better Care Fund plans for both Peterborough and Cambridgeshire footprints following the publication of the NHS England planning guidance for the Better Care Fund, and that had a statutory deadline of the 26th of September for submission. Unfortunately, that was before the formal board, so plans have been submitted following discussions and approvals virtually with the joint chairs, but we're obviously keen to inform you and speak to you around and get your ideas around the plans themselves, and also ensure that you've had an opportunity to comment and retrospectively approve. In terms of the plans, they do relate to this financial year, so we recognise that unfortunately the planning guidance did come out late, which is unfortunately not uncommon with the Better Care Fund as it happens at the moment. So this does relate to the plans up until the end of March. We have very much adopted, in line with the national guidance, an approach of local continuity. So it's very much around continuity of local plans and ensuring we continue on the good learning that we have had over the last few years throughout the pandemic and more recently. We are hoping that we will get guidance for next financial year a bit later this year, and we're also hoping that when the guidance comes for next financial year, that will be more reflective of some of the changes that we are seeing coming forward and be more in line with the Health and Social Care Integration White Paper and some of the wider reforms. So I just wanted to kind of note that, because at the moment this year's, unfortunately, the planning guidance hasn't really been reflective of those changes. We have submitted, which are attached as appendices, all the detail of the plans, but you will notice that we have a joint narrative for Peterborough and Cambridgeshire, which very much brings together that sort of joint vision and that joint governance, and how we take that forward. But we do have a requirement to submit separate planning templates, which can include all of the detail around metrics, finances, performance, as separate templates for Peterborough and Cambridgeshire, which very much align with the local authority footprints. In terms of kind of a high level summary of the plans, we followed the template, but very much it's about building on the plans from last year, and very much bringing them into line and refreshing them in line with the wider changes across the system. So making sure that we've got a clear alignment with the wider system, governance, priorities. Very much our priority continue to be for more prevention and intervention approaches, shifting to much more around place-based delivery and how we address health inequalities in that sphere, and also around hospital discharge flow. So very much kind of building on integration across those arenas, but the plans bring them very much in line with how that aligns with our priorities, joint priorities of the Health and Wellbeing Board and the integrated care system. We currently are awaiting our assurance back from NHS England, which we are hoping that we should receive probably, if not later this month, November. Initial feedback from the Better Care Fund support team has been very positive, and so far we've had very minimum questions of clarification. So we are hopeful that we should receive our assurance status in the not too distant future. I'm going to stop there because I'm conscious there is a lot of information in the annexes. The plans are quite long. I'm hoping people have had an opportunity to read them, and I'm happy to take any questions.
Thank you very much. Any questions or points that people have got about the submission that's gone in that people need to raise? Sorry, Liz.
Thank you, Chair, and thank you for the report. It wasn't, I'm happy with the submission. Some districts have got mobile wardens, and we find that a really successful model of keeping people in their own homes and being able to provide support that maybe otherwise isn't available in the system. So my question was just, how can schemes like this be embedded into the Care Together model, so that services transition to a more place-based approach?
Yeah, no, thanks. Thanks, Liz, like that are really, really crucial. See, in terms of our Care Together model, it's initially sort of over the last 12 months piloted in East Cambridgeshire, and it's been obviously it is a new way of working. It's quite a significant transformational change, and we recognise that it will take time to evolve the delivery that we're doing and how we actually strengthen those relationships and those models with the local communities and districts and wider. We are now in a position where we have actually now recruited to a number of the wider posts, including a strategic lead for the Care Together programme. So moving forward, we are looking at rolling out Care Together across Cambridgeshire and the remainder of the districts. And I think what would be really good, Liz, and I'm more than happy to pick up contacts outside of here is to make sure that there is a really strong link in around those as that program rolls out into the wider districts. But completely welcome your point. It's very much around bottom up creation, so it's very much around getting out and working with the local services, the local people in the community, and understanding what some of those gaps are. So it is a really large scale change in the way that we're delivering. It's a journey. It's not going to happen obviously overnight, but it's really important that we are maximising all of those opportunities.
Thanks, Caroline. Yes, and I think helpful to pick that point up separately, as you say, with Liz. Paul,
more than happy to.
Yeah, thank you for the report. It's really helpful. Taking on Liz's point, I just wonder, under the ICS construct that we're now working and thinking ahead to next year, do you think there are ways in which we can improve the process so we can engage with all system partners to make sure that very good examples of how we can best use our Better Care Fund can actually be factored into our submission for next year?
Yes, I do think on a number of levels, Paul. So I think firstly, from a sort of earlier conversation perspective, really recognised that it's challenging this year, because of the late nature of the guidance, unfortunately, yet again, and where we already are, but also because of the significance of the governance changes and the embedding of that. That has been a really large scale piece of work. I think going forward, we are now, we have a really clear lead in the ICS, Stacey Coburn, who is in charge of performance and assurance, director of assurance and performance in the integrated care system, is now the SRO from integrated care system perspective for the Better Care Fund, which I think is great. So we've got that really kind of high level lead. I think that we need to look at a place-based level and the associated boards that we have got we're having the right discussions around the Better Care Fund in there and wider, because we recognise that the Better Care Fund is one vehicle amongst many to deliver the integration and the vision that we want locally. I believe North part at the moment is looking at some of the membership, around trying to strengthen membership, particularly around sort of community groups, voluntary sector on some of their partnership boards, and potentially counsellors. I think that would be a really good kind of model to look at. I think South are also kind of having a look at that too. So I think I think there is definitely opportunity. I think we do need to look at making sure that we've got much more community level presence in those discussions.
Thanks, Caroline. And I should just say here that we had an informal development session as a group earlier today, and I think one of the themes of our conversation was to find ways into issues such as this far enough out that we can shape them strategically, as well as doing the job of assuring ourselves about the submission. So I think what you've just said, we should definitely think about how we use that next year in a way that that we can use the assets of the wider forum to shape it at an earlier stage. So we'll pick up with you on that specifically. Just looking around. Great, thank you. Oh, sorry, Julie, I couldn't see. Sorry, Julie.
That's okay. Thank you very much. Thank you very much for that. I thought that was really interesting. And the paper, whilst long, did outline quite a lot of stuff. I do think, though, that actually one of the things that you mentioned was actually about the voluntary and community sector and engaging with them earlier to enable them to actually be able to develop the programme with you. And what I do want to say is part of the areas funded by the BCF should be about the voluntary sector capacity and support. And we need to think about that earlier, because we know that we're all stretched at the moment. Everybody's stretched. And therefore, if you want engagement with the voluntary sector, you need to talk early enough for them to be able to fit it in, because their capacity about how many boards and committees and groups they are expected to attend far outstrips the capacity at the moment. So I would welcome some conversation revolving around how we can enable that to happen.
Thanks, Julie. And I mean, by all means respond, Caroline, but I take it as read that as part of that process, we do need to think actively about making sure that engagement happens at an early enough stage in the way Julie's described.
Yes, yes, it does. I completely agree with that. And there's a capacity to, to be involved in multitude. And I think that's why it's really important that we make sure that we target your involvement in the right forum, so that we're actually bringing you to the right discussions early enough, and you're getting benefit out of that as well as us, because you can only spread yourself so thinly. And I really do think we've talked a lot about community. We know that place-based delivery is kind of at the very much at the heart of what we want to do around the integration journey. There is obviously we've got our Care Together programme from a local lead, but we've also it's very much a strong priority in both the North and South places around integrated neighbourhoods, and there's that alignment and that real opportunity around those, about making sure that we're bringing those together as closely as possible. We're really maximising those opportunities, and we're making sure that we are engaging as early as possible with the communities, including the voluntary sector and wider, Julie, to inform that local development.
Thank you very much. So I think there's a sort of set of issues there about engagement, both thinking about how we engage with this early enough to shape it going forward, both with the voluntary community sector, but also with the partnership more broadly, which we will take on board. As far as the specifics of this submission is concerned, obviously the chairs did sign that off in the timescale. It did also go through, I know, one of the ICB's committees in some detail as well. So I think I'm inviting the group to note the fact that those submissions have been made. Caroline, thank you to you and also to Sandra for joining us and for presenting that today.
Thank you.
Thank you. Right. So the last of our sort of immediate business items is regarding the pharmaceutical needs assessment. Ian is going to join us, Ian Green, to talk about this. Ian, you did sit there back in July and took us through this at that stage. So I think people will have had the chance to see quite a lot of the content before, and also what's in the papers. But now bringing the story to its conclusion for this period at least. So over to you.
Yes, thank you, Chair. And I'm not going to go through the P&A in detail. As you just said, it came to the board in July. And at that meeting, you agreed to give delegated approval to the chairs and Director of Public Health to approve the final P&A. That was done last month. So the P&A has now been published. So the board has met its statutory duty to publish the P&A by the 1st of October. That went live end of September. So the board has completed that. So I really want to focus on the results of the public consultation and the bits that the board asked me to incorporate in the P&A at the last time we met. So the last time we met, the P&A was still out for its consultation, hadn't quite finished. The report goes through a snapshot of the results. There is a full report on the public consultation in the back of the P&A. Unsurprisingly, the main concerns, if you like, were regarding opening hours, and that came up both during the consultation and at the P&A workshop we held prior to the P&A being published. Generally, the public were supportive of the number of pharmacies, so it didn't change the initial recommendation that there are enough pharmaceutical provision across Cambridge and Peterborough. So that still stands. So our original assumption was correct. That's been borne out with the consultation. In terms of the other concerns, there was a concern regarding population growth. That is a common feature of each P&A we do, which just reflects the nature of Cambridge and Peterborough being a fast-growing area. In terms of the changes, so the board wanted us to look specifically at the opening hours of pharmacies. The board also asked us to look at the availability of services by geography and by a certain disease prevalence. So we did some mapping work that's now been incorporated into the P&A that wasn't in the draft that you saw back in July. But the quick snapshot basically is that for services, smoking cessation is the only one that doesn't quite map. So smoking cessation services, we map it against which pharmacies actually deliver a smoking cessation service. There's a gap. So in the areas of highest prevalence, we don't have the pharmacies delivering that service. So that may be an area that commissioners wish to look at going forwards. The other conditions, we could map against a specific service because there's no specific services, for example, to tackle obesity. But what we have done is just map the prevalence of those conditions to give an indication of where the Health and Wellbeing Board or commissioners may want to focus services going forward, or identify particular services that may help in areas of higher prevalence. So we mapped conditions such as diabetes and obesity and hypertension. And then the last one was regarding opening times. There were concerns that pharmacies were either not open long enough or weren't open at convenient times for the public to access services. The public consultation basically said that people can access a pharmacy, and most people were happy with the opening hours. However, when you look at the mapping of opening times, it's very difficult because pharmacies are individual businesses and their opening times is not consistent. So one pharmacy may shut for lunch, the next one may not. One may open between, may close between 1 and 2. One might be 12:30 till 2. So it's very difficult to map and get a consistent picture of pharmacy opening times. However, the maps in the P&A have tried to address that as best as possible by grouping pharmacies in like clusters. And that shows that actually pharmacies are open at the right times. There are no specific geographic gaps in terms of pharmacy opening across Cambridge and Peterborough. There is an area, an issue, particularly in rural areas regarding Sunday opening, because very few pharmacies are open on a Sunday in rural areas, particularly in the southwest of South Cambridgeshire and in the north of Huntingdonshire areas. But apart from that, there's a good geographic spread of pharmacies open weekdays and weekends across Cambridge and Peterborough. So there were no particular concerns raised by that additional piece of work. So those pieces of work have been incorporated into the P&A, and the P&A is now published and now live. Thank you, Chair.
Ian, thank you very much. Comments and questions, Mary? Miriam?
Hello, really comprehensive report here. Just something that, you know, one's hearing quite a lot about is moves to have more pharmacists being prescribers, and the kind of government move in that direction. I just wondered if you had a sense of what percentage of pharmacies within our patch are actually able to prescribe.
We didn't look at that specifically. That may be an issue we want to look at in future P&As. That wasn't a request at the time, so we've not looked at that. Obviously, the way pharmacy is changing will change in July next year when it becomes an ICB responsibility rather than NHS England. So we may want to look at that going forward. We've not looked at it for this P&A.
Perhaps I could just come back. I mean, it may be something that you know, in terms of looking at our workforce development, we want to consider what the opportunity is to develop more pharmacy prescribers, particularly within rural areas.
No, thank you, Mary. I'm sure that's right. James.
Thank you, Chair, and thank you, Ian. I suppose two questions on this, really. One, have you any sense of the impact on the availability and future sustainability of community pharmacies, given the growth in remote pharmacies, mail order, internet pharmacies? And secondly, is there an understanding within Cambridge and Peterborough about the impact on staffing for community pharmacies by pharmacists, given the rapid growth in clinical pharmacists being recruited into primary care network integrated neighbourhoods?
Yes, I'm happy to go through that. So yes, there is. There was a concern from community pharmacies about losing staff into primary care. There's also a general shortage of qualified pharmacists anyway, which sort of added to that. And then you bring in COVID as well onto that. Then, although a pharmacy may not shut, they may reduce their hours because they don't have enough staff to cope with people coming through the door. I think there is something to look at going forwards in terms of the role of pharmacy in the hierarchy of treatment. And if we're going to be using pharmacies to deliver more, then it's going to have to be resourced accordingly. So there were concerns from pharmacy about the capacity of pharmacy to deliver. The P&A is a snapshot in time, and it's up to the commissioners to take that on board and try and address that where possible.
Thank you. I've got Jan and Susan and then Steve. So perhaps can we take a little cluster, Ian, and then come back? So Jan.
Yeah, this is kind of linked to the last couple of questions, actually, which is, so what we've asked people is, does it work now? I think is what the question we've asked. And I think it's a relatively small number of people compared to the population. That's not a criticism, by the way. It's just, I think, just a fact. I think the question I think we need to answer as a group is, what does the future for pharmacy need to look like, and how does it sit in that community model that we've just heard? Because I think that's the next stage for me from this very helpful report, but it kind of leans to both Mary and James's point, which is we need to now be building what pharmacy we need in 5 years' time. And that is, I know there's as many pharmacist shortages as there are other workforce issues. So again, if we're going to build this out, what does that mean? And if you look at things like the Claire Fuller review that and the Fuller Stocktake, that actually does include pharmacy as a critical element in that neighbourhood team. So I think this is a really helpful report. I think we should now take the next step though, but what is the future care model and how does that build in? And therefore, what would the need be based on that rather than what we're doing now?
And as you say, that does, I think, pick up the point that Mary was making. If we're taking a forward look at this, including the workforce implications and the transfer of responsibilities to ICPs for next year. Susan.
I had promised myself I wouldn't say anything unless I really had a question to ask. And I'm sorry, it's a bit pernickety, and I should have noticed it before. But in the list in Appendix 2, the geography, I believe, picks up from postcode towns. And I just thought I would highlight, I've noticed a couple that are actually, the Royston ones are actually village-based. And I point that out simply because it's vital to have that provision in villages where there is very poor public transport for those, and especially for those who might need those services. And we need to keep an eye out on those. And that's something for the future too. Thanks.
Thank you, Susan. I'll take Steve and then offer Ian the chance to come back on anything. Steve.
Thank you, and apologies for being slightly late. I couldn't get anybody who opened the barrier to let me into the car park, and I can see I should be over there rather than here. But aside from all of that, I do recognise that one of the possibilities for deflecting demand away from primary care and secondary care is to utilise pharmacies. Much more than we're doing now. But I do wonder what plans we have to actually educate the general population so that we see some behaviour change away from their natural reaction to want to access primary care. And given the present folklore about the difficulties of accessing primary care, going straight to our A&E departments.
Ian, do you want to respond to that and any other points before we draw this to a close?
Yes, I will do. Thank you, Chair. So in terms of the future and Jan's point, yes, I think the P&A is your starting point in terms of where we are now. We did talk about the training needs to train new pharmacists, and could something work with the Combined Authority and the University of Cambridge or Peterborough to set up specific courses locally to train pharmacies? That might be an option going forwards. That was certainly raised during the P&A workshop. In terms of Councillor van der Ven's point, the issues around borders is always difficult, and the P&A tries to look purely at the Health and Wellbeing Board area. It's always difficult because that's not quite coterminous with the ICS boundary, but we have mapped pharmacy provision across the border. So if you live in Royston, you're part of our ICS, but you're not part of our local authority, Health and Wellbeing Board area. You may get services from both. Likewise, if you live in East Cambridgeshire, you may choose to get your pharmacy services from Newmarket because it's easier. So we have done a mapping exercise, but public transport is always going to be an issue, trying to access some of the rural pharmacies. So that's always going to be an issue. And the P&A tries to address access to services across the borders. And we have mapped the pharmacies immediately outside of the Cambridge and Peterborough Health and Wellbeing Board area to show that there is coverage, even though it may not be within our jurisdiction as an ICS. And the last bit about education of the public, that has been a recommendation of previous P&As, that there still needs to be that ongoing dialogue with the public about the correct use, as we would see it, of health services and where is the most appropriate place to turn up with your particular condition you want to be treated.
Thank you, Ian. And I certainly think Steve's point is, is bound to feature as we think about the transfer of that responsibility next year, along with the other points about the future that Jan has made. So I think we're asked to note both the outcome of the public consultation, but also of the final P&A. But as I say, I think in the course of the conversation, we've also pointed forward to using this as a pivot for some further discussion as we have discussed, which we will do. Ian, thank you very much indeed. So the second half of our agenda is largely focused on what's described as strategy development. We obviously talked about our strategy last time in July, and we talked about the key priorities that we had established, and we're going to go through each of those in a moment. But I think we just also wanted to put this into the lens of cost of living. And so I think we're just briefly going to touch on that first before getting into those 4 priority areas. So in terms of cost of living and it linked to the strategy, Jyoti and Kit. Jyoti, are you first?
I don't know if you want to say anything on this, Kit, do you? No. It's just to introduce the presentation that Vicky PC will deliver in a moment, and to set the context. There's a lot of work going on to address the cost of living around the county, coordinated through the public sector board. So this isn't about reproducing all of that work. The focus of this presentation is really on the potential health consequences of cost of living increases, and to set the context for us when we consider the 4 priorities around what we could do further to mitigate those. So that's the context of this particular presentation. Thank you.
Thanks, Jyoti. So Vicky, over to you.
Thank you very much. I will just share the slides through the Zoom link. Oh, brilliant. Wonderful. Okay, so this is just a quick run through really of what we know about the impact of cost of living increases on health, what we already know, what we expect to see. So just briefly. Okay, so of course everyone's going to be very aware of the way that prices are going up all around us. So prices are going up for many key goods and services. This will affect individuals, it will affect businesses, it will affect public services. And just to run through some of the drivers for these increases, which also sit alongside a decrease in income for some people as well. So the main drivers of the current cost increases are, of course, relatively high rates of inflation, high interest rates, the impact of the war in Ukraine, and also to some degree, the impacts of Brexit in some circumstances. And all added up, this means that costs have increased for utilities, costs have increased for food, costs have increased for transport, and also for accommodation. Oops, sorry, I've gone forwards one. There we go. So the increased costs sit alongside decreased income as well for some individuals and some households. So wages and benefits, broadly speaking, have not kept pace with inflation. Sorry, am I too quiet? Okay, right, thank you. Okay, sorry. Okay. So wages and benefits for many people have not kept pace with inflation. We know that in some cases for the poorest households, income has actually decreased in absolute terms. So universal credit was, of course, uplifted by £20 a week during the pandemic, and that uplift has recently ceased. So the very poorest households have seen a real significant drop in their income. Many households are also still feeling the impact of the pandemic. So the financial impacts there would have been decreased savings for many people and also increased household debt as well. So people are going into this cost of living challenge often in a much poorer financial situation than they may have done sort of pre-pandemic 2-3 years ago. Also in terms of income, we're quite concerned, of course, around the coming winter. The fact that many people who are on lower incomes will not be able to access sick pay if they fall ill this winter. So whether they have to take time off work because of colds, flu, COVID, anything else, many people will not be able to access paid sick leave. And of course, that is a significant chunk out of your monthly income if you have to take a week or two off work. So it's not just the people who are the very worst off that we're concerned about. We're also thinking there's a large group of people who are on slightly higher incomes, but who nonetheless have no flex in their budgets. And we need to remember particularly these people when we think about their access to health services, like getting free prescriptions, like getting free dental care. That might have been something that previously they were just about able to stretch to, but with the increased demand on their limited finances, that these charges are going to start to become extremely challenging and perhaps out of reach. So this slide summarizes what we know about the short-term health impacts of financial stress. And then the next slide looks at slightly longer-term impacts. So we often talk about food poverty, we often talk about fuel poverty. I've even heard about hygiene poverty recently, but I really want to make the point again, I often say this, it is just poverty. So the way it affects your household will have different impacts depending on your circumstances, but it's poverty. There's health impacts to many of the choices that people have to make. So if you have to cut back on food spending, if you miss meals, if you eat poorer quality food, there's going to be inevitable impacts. So for children particularly, that could result in attentional and behavioural impacts. For everybody, it's stressful if you're not eating enough, if you're not eating properly. There could be quite likely to see a shift in what people choose to buy, so away from healthier food and towards cheaper but higher calorie food. And people are also thinking about the cost of preparing food as well. So instead of cooking sort of a thorough hot meal, you may choose not to put the oven on and just to microwave something instead, because that uses far less energy and is going to have that impact on your electricity bill. We're also hearing as well that people are choosing, in some cases, to turn their fridges off, and that's got clear implications for food safety as well. So that's food. Thinking about heating and energy costs. If you have to cut back on your heating, then there's short-term impacts, of course, of a risk of hypothermia in very cold weather. And it's stressful. It's stressful for people to live in cold homes and to feel that they're not able to warm their homes properly. For some people, this will have even more significant health impacts. So for older people, being cold increases your risk of falls. And then, of course, there's the knock-on sort of requirements for healthcare after that. And then there's also the group who have a real higher energy costs directly due to their health. So not just older people, but cold can be more dangerous to a lot of people with a range of health conditions. And then there's the people as well who rely on machines in the home that need power. So I'm thinking about people who have CPAP machines in their home, some people who have dialysis needs, and this really drives up your energy costs and may result in people having to make very, very difficult decisions. And then short-term mental health consequences. Again, I've previously mentioned stress, but it is very, very significant. We would expect to see an increase in anxiety and knock-on impacts on relationships, people's ability to parent as well as they would like to and normally be able to. Quite probably an increase in drug and alcohol use as people turn to coping mechanisms. And in turn, this may well lead to kind of an increased risk of health crises and absences from work. And thinking about people, the impact on health services. So we're concerned, as I mentioned before, that people may be deterred from using health services where there's a cost or they perceive there's an additional cost. That could include dentistry, prescriptions, choosing to get your eyes tested. And there's people also, we think that there'll probably be more demand as well for people who are eligible to get these services for free. And then finally, thinking about the people who are in roles in employment but aren't eligible for sick pay. These people are quite likely in some circumstances perhaps to choose to go to work even though they're unwell. And that's bad for them, it's bad for their co-workers, and it's bad for society in general. So those are the short-term health impacts. Longer term, So thinking, going back to food, so if people are substituting poorer quality food, we'd expect to see an increase in obesity. However, if people have to cut their food intake really down to a very, very bare minimum, then we'd expect to see some weight loss and an increased risk of malnutrition. Longer term, the impact of stress is cumulative, and over the longer term, it will start to show up in people's immune systems and the mental health impacts and debt issues. And it's a vicious circle, the psychological impacts of debt issues as well. Living in a cold home for a long time, particularly if you're older, can increase your risk of stroke. It increases your risk of heart disease and respiratory disease and asthma, which isn't, of course, just older people, that's children as well. So thinking about how people may choose to change their ways of working, there may be an impact in people choosing to work from home less often to avoid having to heat their homes. There may be people conversely deciding that they can't afford the commute anymore and that they're choosing to stay at home, albeit in the cold, so that they don't have to pay for their commute. We're concerned as well about the longer term impacts of people who may choose to heat their homes differently. So we know wood burners, although lovely, are not terribly good for your health or the health of the people surrounding you. And people are turning to all sorts of innovative but potentially dangerous ways to keep their homes warm. And then finally, the effects on children. So we know that children who experience poverty see those negative impacts immediately, in the short term, in the medium term, and then also throughout their life course. So not just in terms of their mental health, but also their physical development, their educational development, and finally feeding through into the employment that they have after they leave school. This slide is really, I probably won't go through it in detail. It's there available online for people who want to, but local system vulnerabilities. So we know that our public services are already feeling the pinch. The energy costs of transport costs, the increased costs of salaries, and also certainly at the moment, a real concern about how interest rates are affecting our spending abilities. Workforce impacts. So we know, again, our local services already found it challenging to recruit and retain staff, and cost of living impacts may exacerbate this. And then the other point on that slide that I just really wanted to pick up on was that we're aware about social care and early years being particularly vulnerable to the increases in in heating and energy costs. And then finally, this is the last slide that I want to talk about. So these are just some local links that summarise the support that are available to our residents. Across the councils, Jyoti's mentioned that our response is being coordinated with the Public Service Board. There's some work, I believe, ongoing with the health services to think about how we can work with primary and secondary care to make sure that clinicians are aware of what services are in place to refer people to, and that clinicians and health services are considering the social background and the social pressures, the financial pressures that their patients are experiencing. I think I'll probably leave it there. We are also bringing together data that's available on cost of living impacts across the councils and across the health service and also the voluntary sector, and aim to have a kind of information pack, an initial information pack available for people to use quite soon. Thank you.
Vicky, thank you very much. And I think, Jyoti, the plan was to sort of use that as an essential primer for looking at each of our priorities. People obviously will be aware of quite a lot of that, but it's useful to bring it together in one place. So Vicky, thanks for doing so. I'm conscious we need to move on to each of our priority areas, and I think Kit and Jyoti were going to start us off. I'm also conscious that Vicky needs to leave us by 2:30, I think, at the latest. So we'll probably want to juggle the priorities round a bit and perhaps be mindful of that in terms of introduction. But in terms of the overarching strategy, over to the two of you.
I'll kick off and then Kit will add. So what we're receiving today is the progress on the strategy development. The overarching strategic approach has been out to engagement, and that has now closed. There has been general endorsement for all of the priorities. There's been no objections. There have been some further detailed comments relating to each of the priorities, and they will be fed into the priority development between now and December. I think we've made quite good progress so far, and there have been several comments made to me by the SROs that we're actually having these conversations now, and I'm learning about what you're doing. Isn't that great? So, you know, I think that's a success in itself. And the fact that we've got 4 presentations here today that have been developed in collaboration with SROs from different parts of the system, I think is another success, and we will use that as a platform to continue to build. What you'll receive today in each of the 4 priorities is essentially the stock take that they were tasked with. So they were asked to be clear on what they want to achieve as a priority, what's already there to help delivery against that priority, and an assessment of that, what's working well, what do we need to do more of or less of or differently, as well as some quick wins and some real system challenges. So that's what you'll see in the presentations that follow. Thank you. That's all I wanted to say.
Thank you. I just want to add a little bit more around the engagement. So the work that Jyothi's referenced that has closed is the engagement we've done with existing system partners and groups around those 4 high-level priorities. However, on the 7th of October, we launched a campaign called Let's Talk Your Health and Care. And so hopefully people have seen this campaign. And that's about how we engage with our people and our communities. And one of the things that this board is committed to doing is really to listen to our communities, to bring in that voice and really to collaborate on what matters to the people we are serving. And so we are asking for all partners to help support that campaign and make sure that we promote that widely. It launched last week and we've had 720 responses so far. We're aiming to get up to 5,000 to 6,000, so we will need everyone's support by the early November. But some of the early indications really hint around the things we've heard about in a report from Vicky: access to mental health, concerns people have around the cost of living, and also around access to services. And so we will play that into the strategy and plans as they refine as well. And then once we have that feedback, we will play that back to our public and communities to make sure it's fully integrated into the strategy.
Thanks, Kit. So we've got about 50 minutes or so to just go through each of the 4 and to, as Jyoti says, understand the content in each case and the progress that's been made, but also to ask the questions about what's missing against the 4 that we previously agreed. I'm going to take Vicky Evans and Stephen Lagood first, if I may, because I know Vicky needs to go, and I think Vicky's about to pop up on screen, as is Stephen, so that's perfect timing. This is priority 4 about promoting early intervention and prevention measures to improve mental health and well-being. Vicky, over to you.
Thank you, John. Apologies, colleagues, for not being with you this afternoon. I'm hoping the slides have been shared and that you can see them on the screen. Can you just confirm? See them?
We don't appear to yet at the moment, but sorry, just coming, I think, is what Kate's saying.
No problem. In the interest of time, I'll continue. So for myself and my colleague Stephen, I'm grateful for Stephen joining. He has recently joined as the 2nd SRO for the mental health priority. And I'd also just like to express thanks to Kathy Hartley, who I will stress that we are building on work that she was already undertaking, which is to build a really comprehensive strategy on how we can promote the early intervention and prevention within mental health. Our engagement processes have consisted of a full workshop with a number of key partners, and we have also built on some engagement that Kathy and the team had already begun with some time ago. The first slide I will canter through, which gives really the reasons that you're all familiar with as to why we're here and why we chose the priorities. And within mental health, we talk about the drivers there of suicide being the biggest killer in under 35s, and health-related behaviours such as increase in bullying and a decrease in good life satisfaction, really manifesting itself and impacting on health outcomes across the whole of our communities. So following on from that, we have looked at ultimately what are the causes of mental health challenges and things that are causing mental health to manifest in our communities. And I think it's fair to say mental health illness is affected by a really wide range of variables. And what's recognised by the whole system when we talk about prevention is that our actions need to reflect the many variables that can impact on people's mental health. It's interesting listening to the previous presentation, which reflects on poverty, and that is absolutely a driver for poor mental health in our communities and those within our system, as are things like low socioeconomic status, poor housing and living conditions, adverse learning environments, and all of these then lead or can lead to other challenges such as poor nutrition, low self-esteem, malnutrition, insecurity in people's jobs. And we start to see some real commonality between the determinants of mental health, and actually they are similar determinants of some of the other challenges that we face in the system, such as drug and alcohol abuse, serious violence, low attainment at schools. So there's some real correlation between this and some of the other big hitting strategies that we own across the partnership, and also some direct links across to some of the other priorities, which shows obviously that we are focused as a system in the right areas, but also I feel creates great opportunity for join up across the priority areas so that we can actually maximise our effect and be as efficient as possible. If you just want to move on to the next slide, please. This just outlines the consensual framework for public mental health and talks about recognising we need to tackle for the individual, the family, the community and structural. We have predominantly focused on the bottom three, family, community and structural, because here we're talking about improving population mental health, particularly in relation to prevention and early intervention. So we need to look at what are the things that we can do that can make a key difference. And when doing our stock take and considering that and the evidence, a clear theme that came through to us was the impact of mental health on young people, but also the consequences of poor mental health in young people in their later lives. So for instance, over half of all mental health problems have been established by the age of 14 years old, and that rises to 75% by the age of 24 years old. So when we're talking in the frame of prevention and early intervention, there's an evidence base there to clearly lead us towards how we support young families, young parents, and also young people in their early years, and consider how we can build their resilience, help them understand how they can manage the early signs of mental health and actually protect their own well-being, to start to stem some of the demand that we are already seeing in the system and are likely to see continue to increase over the next 5, 10, 15 years if we don't start to think differently about where we focus our attention. As far as health outcomes, life expectancy for someone with a serious mental health problem is 15 to 20 years less than the general population. So again, for some of our priorities around how we actually improve those, mental health is a real key factor and something that we need to focus on. Do you want to move on to the next slide for me? So our stock take with colleagues identified that there is already a huge amount of work going on in this area, but also highlighted that because the determinants of mental health challenges cross so many strands of work, that there is a lot of work that's happening outside of the health system, which run along similar themes to tackle the challenges and the determinants. But within health, we have already got a suicide prevention strategy that has been designed and written and will be a key part of this strategy going forward. We've got the mental health and the workforce strategy, drugs and alcohol needs assessment, children and young people's mental health strategy, the joint needs assessment for mental health, which is ongoing work, and also the draft population mental health strategy that Kathy and colleagues have already been working on. That is a large amount of work and research and evidence base that we have considered when building these priorities. But along the side of this slide, you can see some of the other cross-cutting areas, such as children's and adults safeguarding boards, which are obviously intrinsically linked in the looking after of some of our most vulnerable children and young people and adults, and are also charged with considering some of the factors that impact on mental health, such as positive such as poverty, attainment at school, good relationships, etc. Pre and postnatal support is another area, criminal justice, domestic abuse, and also the partnership and place work that happens across our districts. So there really are some key interconnections which we have considered, but also see a real opportunity to build it on as we go forward with this work. Along the bottom box, we've referenced some of the key agencies and touch points when we talk about how we prevent population mental health and signpost people to correct services. The group considered that schools, general practitioners, midwifery, housing, social care police and employers are some of the key touch points that the vast majority of the population will come into contact with in multiple different ways. And you'll see when we come to the themes and our priorities, we identify that there's a huge opportunity there to harness the whole system and consider how they can play a part in signposting, supporting early intervention and education around mental health, so that we can start to educate the population about what's available to them and how they can support their mental health and well-being in the early stages and through their families, through things like enriching activity and good relationships that may prevent demand streaming into the higher end of the system. Before I come on to themes, I'm just going to pause, Stephen, in case there's anything you want to add at this point before we move on to some of the key themes that came out of the stocktake.
Thanks very much, Vicky. I don't think so at the moment, and I'm also conscious of time, so I'll let you continue.
Thank you. If we just move on.
Sorry, Vicky, just to interrupt briefly. So if just to give the people around the table a bit of a chance to get onto the sort of what questions they want to ask. So if we could draw that bit to a close reasonably quickly, that'd be really helpful.
Absolutely. The next slide shows the key themes that we have come up with, and I'll go into each of those in detail on the next slide, so I won't dwell on that any further. We've got communications and resources, support and fostering positive relationships, improving the tools to motivate people, facilitate system leadership, and more activity upstream on prevention rather than triage. So our key quick win or urgent priority, we feel, is the communication and resources. We know that there are numerous pieces of activity out there, such as How Are You and Hey and others, but there's a real opportunity to have one system-wide access to early intervention and prevention activity that is accessible to the public, and also a suite of stakeholder tools. There's many at the moment, but the system tells us they're quite disparate. So that is one of our key priorities. Our next is looking at education, because young people are critical. So our priority is to look at what system-based interventions we can have in schools based on anti-bullying, relationships, early years, and also to link with the parenting and families' health priority so that we can weave more mental health resilience work into existing capacity. There are short-term aims, our medium-term aims are system change through system leadership. The system tells us that pathways are challenging capacity and that there is a lot of triage and people in waiting queues, which is actually preventing practitioners from either looking at prevention or dealing with actually treating people. So there's a longer term system aim there, which will link to the joint need assessment as to how we can actually reshape some of the system, stop doing some of the interventions that the evidence base tells us isn't working, and move that activity to support earlier peer interventions, relationship support, to actually prevent people getting to the point where they need critical support. As far as challenges, which the board asked us to ask, the biggest challenge with mental health is how it cross-cuts across a number of different themes. It's quite a complex system, and it's one that is significantly under pressure. And the best way we identify to deal with that is to try and harness across the various work streams and create capacity by building on existing work that are dealing with other priorities rather than duplication in the system. I'll stop there and won't go through the other slides, Chair, but obviously Stephen and I will be happy to take questions.
Vicky, thank you, and Stephen very much for that update on the work that's being done and also for the work that's going on. Richard.
First of all, thank you. I think the fact that you, Vicky, are leading on this and the police as an agency is leading on it is a fantastic sign that we're trying to do things differently. So I congratulate you on that, and I hope that you'll continue to be able to put the time, energy and thought into this that you clearly have so far, Stephen as well, of course. I think we were talking this morning about having honest debates, and this is an area where the system is not working successfully enough in Cambridgeshire, and we should say that. The recent public scrutiny that we did of CPFT, the Health Watch report from 2021, shows that there are large numbers of people that wait a very long time and they get to the top of the queue, and then it's the wrong level or the wrong type of service that doesn't meet their needs. CPFT, to their credit, with the other agencies, have introduced a new system, United, to try to get better coordination and people getting the care they need. I commend them to that, and it's too early, I think, to test it, but we should say that, and I would regard that as a key success factor going forward. I think we need to acknowledge there is a huge mental health crisis at the moment. Nationally, that's true. It's true in Cambridgeshire, and certainly from information we have in terms of children's mental health and boys' mental health following lockdown, there's a huge spike in that, and I think we should acknowledge that. The final thing I'll say is, I don't see in that presentation, and perhaps it's too early days to see it, but it's feedback I give probably to all the strands. How will we know when we've been successful? If we're setting out a strategy here, there's lots of good things that we've just heard, but I won't know in 2 or 3 years' time whether we've been successful. And I think we need to identify KPIs or key success factors or whatever we want to call it. I'm not asking you to invent those today, Vicky and Stephen, but I think we need to do that in this strand and all the strands.
I'll take a couple of points, then bring back Vicky and Stephen at the end. Liz.
Thank you, Chair. Thanks, Vicky, and I know it's a lot of work doing these things, so thanks to everyone involved. The thing you said about communications interested me. So you said there's loads of stuff out there, but it's a bit of a sort of hodgepodge, and there needs to be sort of something a bit more single and standardized is kind of what I took away. And I guess I'd question that. So if we're really going to operate in a sort of place-based way, sometimes hodgepodge and higgledy-piggledy actually works really well. And it's about filling in the gaps rather than, I think you can lose a huge amount of goodwill from what is there if you try to replace it with a single vanilla solution. So I just think that's the challenge for all of us.
I think probably that's my not making myself clear, Liz, apologies. It's not so much that we need one single version, but what came out really strongly from the engagement with lots of partners is that a lot of people don't know what's out there, and that's why I say it's got to be very carefully linked to things like the place space. So it's not necessarily one single place, but it's actually the key people. If we choose a place, whether that's a district or even more hyperlocal than that, it's how do we make sure that the right people know that that's available? Because certainly even within the room, and when I have been out and engaged with wider partners, there are wider partners who could be signposting people to local products, such as the various how are you sites, etc., and they don't even know they exist. So it's more about understanding what's out there, the right people having the right information, but also challenging ourselves to say, is it actually accessible and usable to people who are struggling and in chaos, perhaps in a little bit of personal chaos, because it takes quite a lot for somebody to take those steps, and we need to challenge and perhaps understand whether the product is right for the people who need to use it. So it's not necessarily one size fits all, but it's the right people knowing and being able to signpost to it.
Thanks, Vicky. And so I suppose just sort of concluding, how quick is the quick win, and Richard's point about what would success look like? What's your early thoughts on that?
So I think what success would look like if we take the communication purely, that's an easier one, is around improved access, how many people we can actually physically train so that there are some good evidence bases around training volunteers to signpost appropriately to various different angles. So that I think is more easy to measure in the sense of metrics, but may not necessarily show immediately in a decrease. The challenge with the education is we're talking about a long-term measure there, because we're talking about improving young person's mental health for their adulthood, but we should be able to measure that in referrals from schools, pushing people into early interventions and peer support rather than them accessing the clinical system. So there are absolutely measures there. And whilst we have considered them, we haven't finalised a set of measures yet. But the final strategy document with the consideration of those measures is well underway in draft form and will be with the board in time for December.
Lovely. Thank you very much, Vicky and Stephen. Conscious that, as I say, if we can take about 15 minutes on each of these and allow sort of a balance of time for giving us the feedback, but also allowing people to sort of raise some questions. But thank you both very much for the work, and we look forward to hearing about the next stages on that one. Can I move us on to priority 1, which is about children being ready to enter education and exit and prepared for the next phase of their lives? And I think we've got Matthew and Jonathan. So
Thank you, Chair. It's actually Steve Bush. I'm Director.
Oh, Steve, sorry, I didn't see you there.
Yes.
Sorry.
Thanks. And thank you to everyone for allowing me to join remotely. I would have rather have been in the room, but thank you. I'm Steve Bush. I'm Director of Children and Young People Services at Cambridgeshire Community Services NHS Trust. And I am indeed here on behalf of Matthew Wynne, who's Chief Executive at CCS, and Jonathan Lewis, who's Director of Education at Cambridgeshire and Peterborough. And they are the joint SROs for this priority. Like the last presenters, can I just ask, are the slides available to be shown on the screen?
I think.
Thank you very much.
Coming up.
Thank you very much. That's great. And yes, we're looking at the priority for ensuring our children are ready to enter education, exit, prepared for the next phase of their lives. So if we can go to the next slide. The first point just to make is, like the other priorities, this of course is a system challenge. It won't be just one part of the system that needs to be working to achieve this aim. And so that picture on the right shows that actually young people, children, their families, of course, have contact with providers and other helpful adults from the health world, from education, from social care, and from the voluntary community and social enterprise sector, of course, as well as with other community members. So we really need to think across the whole system to be kind of able to achieve this priority. And we have a system partnership in the Children and Maternity Partnership, which is working towards that. And of course, we're using the lenses of addressing health inequality, population health, looking at the wider determinants of health, to think about creatively how we can achieve this in the system. And equally thinking about, wherever possible, doing this in a place-based way, because obviously that's best for young people and families, but also helps us to address some of those inequalities that might go unnoticed otherwise. Could go to the next slide, please. So one of the things we wanted to ensure we didn't do, which I think was mentioned earlier, was sort of wipe the slate clean and start again with a brand new sort of strategies. We really wanted to look at what's already working in our system. And here you have a number of different strategies with different forms of governance. Of course, the green and the blue reflects whether they're reported through the ICB or through local authority channels. But really thinking about them in groupings that hang together when you look through the eyes of a young person or a family or parents and carers. So we've identified 4 working areas as a partnership that's a little bit wider than this priority, but definitely will be what we think about in terms of achieving this priority. So we have a perinatal and early years kind of grouping that should be a whole system approach, right the way from pre-birth, right the way through to children entering school. And then also linking to the last priority, of course, we need to think as a whole system around emotional well-being and mental health as it interlinks with the ability to kind of enter school well, and of course, exit and transition into adulthood. We also have an area of work where we're looking at special educational needs and disabilities, as well as neurodiversity all together as a whole system conversation. And lastly, looking at the interface between community and hospital services. And of course, there are cross-cutting priorities across all these areas, but this is what we're using to build upon to help us take the next steps as a partnership working even more closely together. So we could go to the next slide, please. And again, please. So I'm just going to give one example that comes from a Best Start in Life program. This is obviously a really important strategy for helping us think about young people entering education well. And I'm going to talk about one case example that comes from a part of this strategy, which is in the top left corner on that diagram on the right, one team defined by place. So that's one part of this strategy. So if we go to the next slide, please. So this is the example of the 2.5-year health and development review, which previously on the left-hand side would have been something that was provided in relative isolation, it's fair to say, by health visitors. And it would have meant that a family received an invitation by post, and they would have been given an appointment at a clinic to come and see a health visitor they might have known previously, or it could be someone that they hadn't met before. And one of the challenges we found was that there was a relatively low uptake for people coming in for those appointments. And of course, that's a real source of health inequalities when you think about which families might be struggling for that to hit the top of their agenda with all the other things they're trying to get through in the day. So we wanted to think a bit differently about this system, and I'll just quickly move on to the sort of right side, just in the interest of time. Sorry, back one slide, apologies. Just on the right-hand side of that slide is where we've got to with some pilot projects, which is where these health reviews are actually completed in the places where families are already attending and engaged, such as nurseries and child and family centres, and happening as a kind of multi-agency approach. So they're still led by health visitors, of course, but they incorporate the knowledge and experience of those nursery nurses and other staff at the child and family centres who know the families well, who are doing this kind of work anyway as part of their work. So this reduces duplication, and it gives a much fuller view of actually that young person and the parent and family support that they have. So it's moved to a kind of multi-agency approach that is place-based in the sense that it's happening in the places where people are living. So if we go to the next slide, please, because this will very quickly, I think, be expanded through the Family Hubs program, which we're very lucky to have support locally for, both financially as well as the commitment that our councillors have provided for this program in Cambridgeshire and Peterborough. And this is really a program that's about improving access, increasing connection between services, professionals, different sectors, and really focusing on family relationships. So there's lots of links, I think, to what was discussed in the last presentation, in the last priority area. But this will be about thinking about how do we come together as multi-agency virtual teams, perhaps, or co-located teams to do our work in ways that are more efficient and work better for families. So if we could go to the next slide, please. And again, please. And so we just wanted to share some thoughts for further areas that we may want to go with both of these aspects of this priority. So in terms of entering education, we really would like to think wider, not just in terms of the immediate providers I've spoken about so far, but also about how we can increase uptake of some of the social support for families where it's needed in order to support children living in those families. How can we support the importance of play, which we know is connected with good development and educational attainment? How can we do that from early years so that by the time children are ready to start school, they've had that grounding in cognitive development? Also, how can we support parents? So thinking very much about the alignment of the perinatal support and midwifery teams. So that's a joined up approach that really prioritizes both mental health as well as a wider view of parental stress that may, if not supported, could develop into mental health problems. So making sure that children are growing up in families where parents have all the support they can get to tackle the very challenging task of parenting well, which we all struggle with who have children. And then lastly, thinking wider about the environment. How can we make sure that children are living in conditions that are supportive of the mentoring education well? And underpinned beneath all of these, the enablers will be, of course, things like shared care records, shared digital platforms, which provide content for parents, universal offer of information, also for young people to use when they're getting older, and also potentially shared local premises where we can come together to deliver our services. and very much aligning our local ambitions in each place with a program that spans the system, which is family hubs, which might be slightly different in local areas, but actually is something we're doing across Cambridgeshire and Peterborough. So we can go to the next slide, please. This is thinking a bit more about the other side of the priority, exiting education well and preparing young people for the next phase of their lives. And of course, there's an economic aspect, which we've heard about. So helping families to have the support that they need in order to support their young people to meet their potential. But also thinking about making sure there's awareness about apprenticeship opportunities and careers. Addressing particularly, I mean, we need to think about transition to adulthood right across the population, but particularly thinking about areas of young people experiencing mental health or with special educational needs and disabilities, because those are particular vulnerabilities for that transition period into adulthood. So that's a particular focus. And then obviously focusing on excellent education so that young people have the very best launch pad for them to go into their adult lives. And again, there are some important enablers which are around bringing data together across the system, and also potentially seeing schools as a kind of hub where we can come together again to make contact with young people and provide a joined up approach to supporting them in a sort of holistic way. So if we could go to the next slide. And this is just our thoughts about wider support that we would like to kind of consider with you. So thinking about how each local area can contribute to every child being ready for school and exiting school. So that may be about supporting the Family Hubs program and making sure that that's interlinked with other developments like the integrated neighborhoods, but also thinking about how we help young people explore options for the next step in their lives and really making the most of what's out there for them. Because that's our future generation, obviously, so it's of critical importance. So thank you very much. I think that's the last slide.
Steve, thank you very much indeed. As you say, in those areas for discussion quite a lot, I'm sure we'll want to come back to, but immediate points that people wanted to respond to in terms of the work that Steve and colleagues have been undertaking. Jan?
It's a bit of a hybrid comment on this and the last presentation. I was at something earlier on this week, and again I was reminded of the Bromley by Bow model for organising healthcare. And it really isn't about organising healthcare at all. It was a community solution, really owned by the community. And I'm just looking at your presentation, Steve, which was really, really helpful, and thinking, are we as a board being creative enough on how we use commercial sector growth, etc.? Because one of the things that struck me on Bromley by Bow is just how much of that was local businesses who really owned a lot of that as well, because they understood the value of investing in things like services for children, because actually it was their workforce of the future, if you see what I mean. So, and I know we're thinking about that as anchor institutions. So it's not really a direct question on yours, but I guess it's a question to us as a group, which is, when you know those other models are about, are we being ambitious enough to support programs like this? Because if it comes down to how do we, quite frankly, set all of this up, we're going to hit a problem, aren't we, in the same, you know, in funding. But we've got to make money for this, we've got to make space for this, because if we don't, there's a risk. But I guess it's a challenge to us more than to you directly. But a question for you directly is, I was struck by the last presentation and this as well, which is, we talk a lot about neurodiversity, we talk a lot about mental health. I'm not sure how much we talk about resilience and how much that comes through. And I think you and I had a conversation last week or the week before, and you talked about adverse childhood events. And actually how that is the biggest material impact on outcomes for children. And I just curious to see where you see that fitting, and how we can support you looking at that as part of this world, because it seems to me if we have the centres but we don't deal with the adverse events, as you explained to me, we're going to have a gap.
Steve, can you just hold on to that question for a second? I'll bring in Paul, and then perhaps you can deal with a couple. Paul Med from Finland.
Thank you. So really, really insightful presentation. So a big thank you for that. My kind of questions around the engagement and integration with preschool services and schools themselves. How effective do we think that is? Do preschool services and schools have a real clarity of role in terms of how they can complement what we're trying to achieve as a whole system in respect of this priority?
Steve, do you want to take those two on?
Yes, thank you. Really helpful comments. And I really want to agree with, I guess, all of the points that, both the points you made, Jen, and all the points that were made there, because I do think we've had some really challenging discussion here about, well, even in preparation for coming here today, how much do we present to you sort of, almost the finished picture of what our outcomes will be, how we would know, and that was a really helpful question that came up in the last presentation. I think something that's really important is that we don't rush to the solution with this, because of course this is a really critical opportunity. We know how stretched our provider services are. They clearly won't be able to achieve these ambitions alone. And I think it's really right what you said, Jan, about we need to look wider to our communities and the resources, of course, in those communities, including private sector. And I guess I see the partnership really as an enabler more than anything. I mean, we all have a habit of taking on projects and kind of, setting them up and sort of really doing all the work. But actually, I think there's a critical opportunity here that we spend some of our energy on engaging, because as you said, I think that's really true. And that links as well to that ACEs conversation, because again, it's partly that age-old dilemma: do we fight the fires in front of us, or do we look at sort of going upstream and sort of preventing some problems? And of course, we need to do a bit of both. So those strategies I laid out, they're working really well. I'm really pleased that we're at that stage as a system. They are improving things like was mentioned, the early years assessments. But it's true that actually we need to reach families in different ways and reach them earlier, I think, because there will be lots of experiences like adverse childhood experiences that are happening right now that that could actually, if there was support available, could actually prevent the problems down the road. And I think that links a lot with the previous priority around mental health as well. And of course, we need to do that because economically, that's how we can kind of achieve our ambitions, but also it's the right thing to do. And just to link as well that point to preschools, I think we do have a really good example in that Best Start in Life pilot program of engagement, but we have further to go. And I suppose that's, again, linking to Jan's point, that we need to go out and make sure that we're kind of looking wide and engaging with those preschool providers that aren't actually currently linked in, because this is something that we could offer for all of our children and young people. And if we're going to address inequalities, we really need to be kind of reaching every local area.
Steve, thank you. I'm just going to take Mary and any response and then move us on. But Mary.
Hello, Steve. Really just building on that point about the importance of schools in this. I know one of your colleagues leading the work stream is from education. And I just really wondered if we feel we have the levers within the way education is currently structured with academies and that mixed economy now that we have within educational provision to actually have the impact that we need to have in schools more generally. Is there anything more we could be doing as an ICS to develop those levers?
Thanks, Mary. Again, really sorry, Chair.
Cool, Steve, you go ahead.
Sorry to jump in. Thank you, Mary. That's really helpful, and I do think that's critical. I suppose my thought for consideration, I mean, I don't have the answer to that probably, but just something that I would suggest is that there's a huge amount of power in obviously relationships, and I think there's an opportunity to engage more with our education colleagues within the ICS space. That's my perception, and I suppose rather than levers, I suppose I'm thinking of it more in that sense of when we're coming together and we're sharing outcomes and ambitions, then I think there's a real opportunity there for us exploring the arts of the possible. Because as I said before, I think we all, particularly education, but we all are kind of really struggling with the current situation, all the impact of the cost of living crisis, etc. So it will be about the strength of those relationships, in my view. But I'd be grateful if others have other views as well. I can see Charlotte's hand's gone up, Chair. Thank you very much.
Charlotte, briefly.
Yes, hi, sorry not to be there. John Lewis would have been presenting this jointly with Steve, but we've all been hit with COVID this week. So just to confirm, the local authorities very much signed up to this, and you know, we've got good relationships with schools. And I think, Mary, in terms of the links to academies, I think that we will, I don't think that will get, I think the expectations of, you know, new things that they can take on is obviously quite high. But there's a real sign up to this as a priority area, which is why I know John was keen to sort of jointly sort of sponsor it with Matthew. And thanks to Steve for doing the presentation on their behalf today.
Thank you, Charlotte. And Steve, thank you very much indeed to you. And of course, please pass on our thanks to Matthew and Jonathan as well, and all those involved in it. We look forward to seeing where that goes next, and some real crossover and connection with what we heard earlier on. I'm going to move us on to the priority 2 around environment and giving people the opportunity to be as healthy as they can be, which I think is Jyoti and Lou to share briefly with us. Jyoti.
Thank you. This will very much be a double act, but in the interests of time, I will skip some of the slides so that we allow time for discussion. So the first slide is the classic Foresight obesity map that is just designed to show how complex the determinants of obesity are. If we could move on to the next slide. And my simplification of that is here. Essentially, it's the wider determinants that have an impact on how good people feel, which in turn is driving our risk behaviours, eating, physical activity, alcohol, smoking, etc., which in turn is driving the patterns of illness that we're seeing across Cambridgeshire and Peterborough. The bar at the bottom is designed to demonstrate that if we intervene early in the life course, it will be more cost effective and pay dividends throughout the life course. Thank you. We have set ourselves some measurable ambitions, and they are actually very ambitious, and they are to achieve a 5% decrease in childhood overweight and obesity by 2030. Corresponding to that is to reduce childhood obesity and overweight in a shorter time frame, 2026, to pre-pandemic levels. We also, of course, want to reduce adult overweight and obesity to pre-COVID times by 2030, and to reduce inequalities in overweight and obesity. And finally, we want to achieve a 10% increase in the number of adults who undertake 150 minutes of physical activity by 2030. And we're being even more ambitious for children. We want every child that's in school, that's of school age, to be able to meet their physical activity recommendations. The next slide, please. This is kind of making the case for why we've chosen obesity. So we have prioritized obesity above other risk factors, and that is because of the scale of the problem and the fact that it's going in the wrong direction. It's increasing rapidly. It's also it's strongly associated with deprivation and ethnicity, and Louis will be describing that in a bit more detail later. It has numerous health impacts. It's the biggest contributor to premature mortality. It's associated with the 3 main clinical risk factors that are driving early mortality and poor healthy life expectancy, and they are cholesterol, hypertension, and blood glucose. And there's also that interrelationship that we've heard earlier between obesity and mental health. the consequences of obesity are enormous in terms of impacting on educational attainment, workforce capacity, sickness absence, demand for social care and healthcare, etc. The consequences of this are huge. Could I have the next slide, please? So to Louis for these.
Thanks, Jyoti. So my takeaway message on this slide, I think, is simply that in 1819, we're waiting for the more updated information. 36.9% of our children leaving primary school was overweight in Peterborough and 27% in Cambridgeshire. We go to the next slide, please. Again, I'll count it through quite quickly. What we've looked at here is the links between obesity rates and deprivation. And if you look at the left-hand side of that slide, you'll see actually there is a significant correlation between what we're seeing in terms of obesity rates and areas of deprivation. The difference between the two slides there is simply at reception level and then later on at year 6 level. And actually what we're seeing is the correlation is even more stark when we get to year 6 level. On the right-hand side, we've simply tried to look at adult obesity and again link that to areas of deprivation. And there is a strong link, although probably more difficult to get to, but it's definitely a strong link given the data that we've got at the moment. We can go to the next slide, please. So Jyoti talked about obesity being a common risk factor in cardiovascular disease, diabetes, and cancer. This slide is quite telling, and actually a fact that I've had to get triple checked is that 24.9% of our deaths in CNP in our system is as a result of cardiovascular disease. If you look at the top two charts, you'll see that Peterborough actually is faring really badly, with 26 worse in the country. If we look at all the unitary authorities in the country in terms of our performance on cardiovascular, early mortalities, I suppose, sorry, early mortalities for under 75s for cardiovascular disease. So if we look at that as a statistic, Peterborough is doing really, really badly at the moment. I will say though, and I've said this a number of times when we were preparing the slides, and I know Jyoti has also got a real concern here. Although the data that we're pulling out is for Cambridgeshire and Peterborough, and Cambridgeshire overall as an average looks okay, it looks better than Peterborough. We absolutely recognize that when we delve into it, there are significant issues within the Cambridgeshire population. And I think the danger when we start looking at the stats here is that the average is not our friend, as I keep saying, and we need to be really, really mindful of that. It is easier to pinpoint to Peterborough and say, you know, they are doing worse, but we absolutely recognize there's significant issues within the Cambridgeshire area as well. So cardiovascular disease, under 75s, early mortality, big, big issue, and 24.9% of all our deaths in the system as a result of CVD. If we go to the next slide, please. So we try to do something similar for diabetes, and although less stark on diabetes, actually, again, similar picture, diabetes in Peterborough, if you look at the right-hand side, we're doing much, much worse and slightly better in Cambridge, but I think it comes back to the same point, which is there are significant issues within Cambridgeshire as well. If we go to the next slide, please. We've included the wider determinants of health here. I absolutely recognize, and Jyoti and I have had many conversations about this, that it is really difficult to draw direct comparisons between the wider determinants of health or clear links and the rates of obesity. I do think it's worth noting, though, if you look at the density of fast foods, for example, which is at the top line there, that in Peterborough and in Cambridge and in Fenland, actually, we are far worse in terms of the density of fast food outlets compared to our England average. If you look at something like the dependent children, which I think links to some of the other presentations and under 16s, again, you see actually in two of our areas, we're doing quite a lot worse. And then I think linking to the other slides again, educational attainment at the end, I think there's quite a strong link. So really difficult to link this directly to obesity, but I think it's worth us considering, as other presentations have outlined, the clear link there between the wider determinants of health and what we are seeing in our obesity rates. So I think if I had to summarize the slides that I've just presented, I'd say we know it's a significant problem. As Jyoti already outlined, we know it's getting worse. There is a clear link between obesity rates and deprivation. It is a common risk factor for cardiovascular disease, diabetes, and cancer. And I think those slides are really stark in terms of our existing performance and especially the early mortality. And I'll stop there and hand back to Jyoti. Thank you.
Thank you. Could I move on? We can skip this slide. Okay, so there'll be three main pillars to our approach to tackling obesity: the obesogenic environment and what we can do collectively with partners to address that, behaviours, getting people to be more healthy is a major challenge, and then the socioeconomic factors that we've heard about earlier today that will be driving a worsening position on obesity. So these are the real challenges that we need system support to change, and are the long-term challenges. And move on, please. And the next one, please. And finally, I'll just cover the points in the green, which are our quick wins. We think, we've got children, access to children for 11 years, for 7 hours a day. That is a critical opportunity for us to address behavioural risk factors for children through changing the food that they're exposed to and getting them active as part of the school day. And that will reduce inequalities and have a measurable impact. This can be done. This can be, in theory, turned around in a year. So that's my pitch. We've got to work together on that, though. We're going to commission some behavioural insights. Again, that can be done in the next year. That will inform how we sharpen our interventions and, again, reduce inequality. And then finally, another potential quick win is the identification of adult obesity. We've got very robust measures for children up to primary school. Secondary school is a bit of a gap, and sporadic data on adult obesity. So we really want to push forward identification of obesity through primary care, and then onward referral to either behavioural or clinical management as appropriate. These are things that we think can be done in the next year.
Thank you, Jyoti, and thank you, Louis. What do you want from people around the table immediately?
Support with getting into schools, and the academisation is a challenge to us, but I need partner support to do that. I need partner support to get primary care engaged in the measurement and identification of obesity and onward referral. And I think they're the two key things. We will push forward on the behavioural insights, and then we'll need help with the interventions that come on the back of that.
Thank you. I've got Jan and then Paul. Jan.
I wonder if I could flip the question a little bit to, we have around this table the biggest single employers in Cambridgeshire and Peterborough. We have access to resources, every single party around here that could help this issue. I wonder if what we should be asking is what is the commitment from every single organisation around this table, and what are they going to do for the people they come into contact with to contribute towards this? And the reason I say that is we had the conversation in the earlier workshop, didn't we, about the difference between us saying this is what we're going to do and challenging us to say, what could we do differently? So again, really, there are things we can do in healthcare when people come in that we maybe are not pushing people or giving people the opportunity, as much opportunity as we need to, for access to weight loss programs. There might be other areas that could give people more access to leisure, for example, etc. So, I guess, could we flip the challenge on this one, if it is, if we're starting with obesity, and actually all bring back something that we can do without that needing to be coordinated, but could all build a stronger program, maybe than you would be able to do if you're having to do it through a team of people dealing with obesity? Question mark.
Good challenge. Paul?
Thanks, John. I think it's really helpful actually to hear a clear ask from Jyoti. So specifically the point around what we can do to help and access into schools. I think all local authority colleagues, both at a member and an officer level, we have really good connections with our local schools. So, I think it's an offer back to Jyoti. Please reach out and engage with us on that, and we'll do our level best to kind of help connect this priority with schools so they can understand, the role that they might play.
Thank you, Paul. I've got Richard and then Liz, and then we're going to draw where we are. Richard.
first of all, it's not surprising given it's Jyoti, but this is brilliant and it's definitely outcomes focused, and I can definitely see what the success this would look like. So I really congratulate everyone involved in that. I will say Charlotte's been really ill with COVID, and what she's doing, joining us online, I don't know, but I commend her for her absolute commitment to what we're trying to do. But I think what she said, that our head of education is playing a leading role in this, and we've got very developed policies about how to work with academies, not just direct local authority maintained schools. So that's another good sign that this strategy is getting outside the tram lines. And given more time on another day, I think we could look at that in a bit more detail.
Liz.
Thank you, Chair. I think it's brilliant that your ambition is to turn this around in a year, or you say that's possible. I'm not saying that's your ambition, but it's possible, and that makes my heart jump with joy. So I guess what I took from this morning is we should be challenging each other more. And is a 5% reduction enough? Is my question to you, in terms of one of your first statistics about reducing the number of kids who are obese by 5%.
So Jyoti, Louis, what do you want to do with the feedback you've had in terms of what we do next, as well as responding directly to Liz's question about Jan's point about us all thinking about the wider things we can do?
So I mean, it's all really helpful feedback. I think the one thing I would say is, I suppose what I'm really careful about is, I think quite often we make decisions and come up with solutions that I don't think is really driven by the voice of our population. The piece that Jyoti mentioned, the behavioral insights piece, I think is critical in all of this. And to come back to your point is, are we being ambitious enough? I think the question is, we need to understand a little bit more about the choices that people make and why they make it through that behavioral insights piece of work that we want to do. And I think that should inform then subsequently the kind of ambitions that we would want to set ourselves. But I think at the moment we've pointed to some data, we're working through some data, but I think it's fair to say, Jyoti, we still want to do further work on it. And when we come back in December, hopefully with a better understanding of what's causing some of this and some of the solutions that will go hand in hand with that.
Jyoti, anything finally?
Thank you. The asks that I made were specifically around the shorter term objectives that we'd set ourselves. We absolutely need the system to get behind us for the longer term objectives, and that's what we'll work up between now and December. And I'll take anything that anyone will offer. Absolutely, I'll have your arm off. What was the other point I was going to make? I forgot what it was now, I'm lost.
I'll get rid of my 5%.
Oh, the ambition. I think they are ambitious targets. I mean, every year we've had a year-on-year increase in childhood obesity. I think I would be delighted with a 1% reduction. We're setting ourselves a 5% one. I think that is an ambitious target.
Right. Thank you, Jyoti, and thanks, Louis, and thanks to colleagues for all of that work. And as you say, we'll take on board the offers and the issues that people have raised for what happens in December. So we have priority 3, which is about reduction of poverty through better employment, better housing. Really important that we look at that theme, because it does reflect very much the sort of broader ambitions of an integrated care system as well. Delighted that Joe Lancaster from Huntingdonshire has joined us, but also Liz is here and Fliss, who've been working on this. Joe, is it over to you first?
Yes, thank you very much, Chair. Good afternoon, everybody. I'll try and be brief. We have a few slides, as is the custom. I think we talked a bit about wider determinants of health this afternoon. There is a well-established pattern here about the understanding of the links between poverty, housing, employment, and health. I think the thing that we're trying to do here in Cambridgeshire and Peterborough is tackle a problem that lots of other people have recognised, but not many have faced into it. And what we've done in the first instance, the challenge was to do a stock take, but inevitably we've not done that. So could we have the first slide, please? We've done a slightly different methodology. So this again is something which should be very familiar to people around the table who've been around for Public Service Board over the previous few years. It's a well-tried and tested approach to problem solving, and given the complexity of the interplay between housing, poverty and health, we've decided that to do a quick and dirty stock take would not actually help us. What we've chosen to do instead is to spend some time up front properly defining the nature of the issue, so that we can actually then make sure that when we're developing solution and iterating solutions, that we actually know what we're aiming for, because it is such a vast, complicated issue. And largely what we have as a society is we're very familiar with the negative effects of bad housing. But what we don't talk about too often are the positive benefits associated of good housing. And there's lots of research going on at the moment. Joseph Rowntree Foundation are doing some work with the Nationwide Foundation around just understanding the language of how we communicate about health and wellness and the links to housing. So I'm going to focus a bit on housing, and then I'm going to pass over to Fliss to make the links into employment. And the fact that we're doing this as two separate halves is testament to this early stage that we're at, because to try and conflate both issues into one agenda in this short time period proved to be almost impossible. So we've gone for a pragmatic solution in that discovery phase. So if I could have the next slide, please. So what we've tried to do is capture some of the early issues that have been emerging through our system, and I'll be brief. I'm not going to go through each of these items. You have the slides so you can look at them yourselves. But from a really human point of view, the stories that we've been hearing are about those connections between health and housing in a very visceral way. So when people are coming out of hospital, are they going into homes that are suitable for their recovery? Are we discharging people with ongoing care requirements that are not being accommodated in their housing environment, whether that's a private sector or a public sector landlord? And the stories that Liz and I were hearing from housing officers as recently as earlier this week are really, really tangible human stories, which give us an insight into some of the disconnects between different parts of our system. But equally, some of these early thoughts capture some of the positive opportunities that exist. And what we've not done at any point on these early forages into the system is talked about the limits of money. Money hasn't entered the debate in any of the conversations we've had. There's a realization that there is a systemic problem which we need to face into. So some of the things that we're going to be proposing as we move further through the development of ideas is how we can make the positive experience of housing part of a virtuous circle, which will interlace with some of the early thoughts that Fliss has gathered, to ensure that we actually head into this really, really big issue of prevention. And it's going to take some bold decisions, and it's going to take some risks, because there isn't a perfect solution to this. Councils, health systems have been trying for years to fix this stuff, and at the moment we're all firefighting. So some of these early thoughts, particularly, we've touched upon some of these overlaps already with mental health in particular, and certainly one of the big themes that's emerged for us is that second bullet point around the Home Improvement Agency and how we get more for the money that we have available in the form of grants. And again, that will tie in with public sector landlords and the ability of registered providers to provide better use of the limited money that we have. So if we could move on to the next slide, please. We then went on to a bit more of an expansive thinking about the nature of housing and how it could help with some of our employment issues. And colleagues around the table are very, very familiar with problems of recruitment and retention, particularly for junior roles. And so we've got a theme emerging as part of our scoping work around key worker housing, and how we get hard evidence to demonstrate the need for that, and how we try and use the opportunities of growth that we have in Cambridgeshire and Peterborough to really hit some of these problems square on. And in the short term, we were even talking more practically about, if there are new junior doctors, GPs starting in the area, there are housing providers who could provide short-term accommodation, rented accommodation, to meet housing needs in the short term, and maybe we could explore things like that. But we've tried not to get too ahead of ourselves in coming up with solutions at this stage. There are also some broader issues which we probably need to think about how far we take the scope of this work, and some of the planning related issues have already started to emerge as part of our discovery work, which is, we're in a plan-led system, but unfortunately lots of speculation about land values means that there are always questions about viability. So where do we squeeze the benefits out of housing schemes to better deliver for the full range of housing that we need? Because again, the range of housing that is being delivered isn't necessarily meeting the immediate local needs. And then the final point on this is the one that I will highlight on this slide is the overwhelming story that is coming out of our work so far is that we just need to be better at joining up. We have lots and lots of people working on parallel tracks, and we just need to blow away some of the Chinese walls that exist in our systems to help that visibility of these common problems. The next slide, and the final one on housing from me before I pass over to Fliss. We're starting to look a little bit at some quick wins, so I didn't want to get too far ahead of ourselves at this stage, but there are some fairly easy things that we think that we could move towards doing some pilot work around. Hoarding is a theme that has come up consistently as something which we're not particularly good at dealing with, massive issues in terms of the mental health impacts of that. Hospital discharge, I've touched upon it, and I think there's a question around how we use the multidisciplinary support networks that exist. Districts aren't involved in that, and again, we've alluded to that early on. As housing stock controlling authorities or people who have access to other forms of accommodation, I think there would be a significant benefit from that in the short term. GP housing I've touched upon, and then again coming back to this theme of the Home Improvement Agency and the value that that could bring. Again, in the short term, it's an existing process. We just need to modify how we work. So those are the immediate thoughts. As I say, we've circumvented the requirement to do a stock take, to do something a little bit more structured. But I think in the long term, and I speak for both Liz and I on this, I think the long term, unless we take a measured view at this, we're going to miss it again. And it's such a big target with such a big value at the end of it. So I think we're very committed to this type of double diamond type approach. But I'll pass over to, sorry, Liz, have I missed anything? I'll pass over to Fliss.
Come in. No. Okay, very conscious of time, so I will try and speed through quite quickly. If we could go on to the next slide, please. Thank you. So in terms of reducing poverty through better employment, there are a number of elements that we need to focus on here. One is looking at the current jobs that we have within the system and making sure that we have good work and defining what good work looks like. One is the creation of new jobs, but then also linked to that, and I would say this as Associate Director for Skills, we also need to make sure that we have people with the right skills to therefore be able to access those jobs. A number of the things that we've identified within this priority are very similar to things that have already been said by other colleagues here today. So we need to have that system-wide approach. There are strategies upon strategies upon strategies across this area, and what we need to do is look at how we can work better together and how we can implement them, because I think the vision is there for everything. It's just how do we work better together to get the outcomes that we need. So the foundations for this work are already in place. We were really fortunate to have a DWP pilot with the development of the work and health and wellbeing strategy. So that's work that we've worked with colleagues from the ICS, from public health, and also local authorities and the combined authority. And this really is looking at a framework for a whole systems approach to improving the health and wellbeing of the working age population. And we're currently at the stage now where we're looking to look at the interventions that we've already got in place, look at the impact, and then also prioritise. And there is a paper going to CPSB this month to consider that there. We also have the combined authorities economic growth and also employment and skills strategy. They, by the nature of them being led by the combined authority, have engagement from key partners across the region too. And what we're trying to do through this stream is look at those actions, look at those targets through a different lens to make sure that we integrate health and wellbeing into business and economic growth activities. So therefore the work, the data, the evidence is already there. It's how we can align to achieve more. And I'll stop there.
Liz, thank you very much indeed, and to Joe. Any points, questions that people wanted to raise or issues wanted to raise with what Joe and Fliss have said on this theme and the sort of approach that's being adopted, as you say, not starting with a stock take, but nonetheless, I think sort of really valuable and important. I've got Richard and then Liz. Oh no, sorry, Richard.
the end of the meeting and squeeze, but I don't want you to think that all the work isn't appreciated. It really is. I love the quick wins. I think those are great ideas, but I'm sure you've heard what we said about health outcomes on the other strands. I think I'd encourage you to really push that in future evolutions of this work, and thank you.
Anybody else? Mike.
Just very much to echo what Richard said, I think it's really, really helpful. All of this stuff has been really helpful. And I'll take away one of the points you made, which is whether that some of the multidisciplinary team composition is quite right. You're saying it's not quite right. So take that away. Yeah.
Good. Well, in which case, Joe, Fliss, Liz, thank you very much indeed for that. Thank you to everyone for bearing with us as we've been through that. It was important, I think, that we went through the stock take as we labelled it, whatever way it turned out, to hear about all of the work. And I think thank you to everyone for the sort of energy in the industry and the ideas that are developing. I think that's a real testament to work across the system against the priorities that we previously agreed. Obviously, there's phases that are quick wins and short term and medium and long term. We will hear more about progress that's been made in a couple of months' time. I guess in the context of the sort of medium term, we've begun already, I think, to see some commonalities, some themes, some enablers that we'll want to think about how we fuse over time. And of course, in the context of the conversation that we had this morning, how do we engage as a forum in these in some slightly different and more dynamic ways that we discussed this morning? So important that we've heard the basics this afternoon, but we'll find some different ways into that as we go forward. But thank you to all of the teams for that work. I think we've just got an item on forward agenda planning, partly I think to note, and I'm looking here at Kit and Jyoti. I think for December we have the integrated care strategy and health and wellbeing strategy jointly that we need to at least agree at this point. I think, as we said before, we don't regard that as the completion of our work. In many ways, it's only the beginning, but we do need to go through that process. But in the spirit of this morning, talking with Susan, and we'll certainly think about ways in which we can have that discussion in December. You'll be pleased to know that you'll be spared being chaired by me at that point, and the mantle will be passed over to local authority colleagues. Anything else on sort of forward agenda, just looking at Jyoti or Kit, that we need to note before then and just the build up to December?
That I can think of.
Okay. As I say, thank you to colleagues for both work this morning, but also specifically this afternoon. Anything else that anyone needs to raise before we